PrEP study showed that both daily tenofovir and daily tenofovir emtricitabine taken before HIV exposure can prevent heterosexual transmission of HIV to women, from women to men, and from men to women. The trial followed serodiscordant couples in which one person had HIV and the other did not. Couples received counseling and free male and female condoms. The uninfected partner took daily tenofovir or tenofovir emtricitabine or a placebo pill. Those who received tenofovir had an average of 62% fewer HIV infections, and those who received the combination 73% fewer HIV infections than those who received placebo. The TDF2 trial in Botswana followed men and women who were randomized to receive tenofovir emtricitabine or placebo. Those taking drug had 63% fewer infections than those who took placebo pills. And this trial was already mentioned several times. The HPTN 052 study showed remarkable results with a reduction of 96% in the number of linked HIV transmissions resulting from earlier initiation of antiretroviral therapy as compared with delayed therapy. 3 PrEP studies are still ongoing. The VOICE trial, which also includes a parallel comparison of the safety and effectiveness of a vaginal gel containing tenofovir compared with placebo in women. Secondly, a study in Bangkok which looks at the effectiveness of oral tenofovir among people who inject drugs is still ongoing, is fully enrolled. And the IAVI intermittent PrEP studies, phase 1 and 2 studies, have publications and preparations. These are small exploratory studies to provide preliminary data on intermittent PrEP regimens in African female sex workers, MSM, and discordant couples. A number of groups have started working on rectal microbicide, as receptive anal sex is common practice in MSM and in some heterosexual. We have proof of concept that rectal microbicides work in animal models, and a number of phase 1 studies are ongoing to look at safety, acceptability, PK and PD in different formulations. So we do now have a range of HIV biomedical prevention tools which have been shown effective in randomized clinical trials. Combinations of behavioral and structural intervention strategies to reduce the risk of HIV infection and vulnerability have been applied for nearly 3 decades with differing success. A number of new biomedical tools have demonstrated their success, but all have behavioral components and also structural components. We can't reach relevant populations if stigma prevails and populations are and behaviors which populations have are illegal. I would like to emphasize that in particular from this region we have proof that existing prevention methods are highly effective if implemented at the right intensity and scale. Here an example from Thailand. The prevalence of HIV among female sex workers has decreased between 1998 and 2008 because of the 100% condom program. The 100% condom program is a targeted approach to HIV and STI prevention in sex work setting that has enabled sex workers to demand condom use and access STI care. WHO, UNODC, and UNAIDS recommend a comprehensive package of 9 harm reduction interventions for people who inject drugs. They should be implemented in conjunction. Needle and syringe programs and opioid substitution therapy are highly effective in reducing HIV acquisition among people who inject drugs. Ladies and gentlemen, Translating research to implementation is complex and will take time. PrEP is a complex intervention requiring exclusion of acute HIV infection and monthly or probably 3-monthly HIV retesting. First of all, services for PrEP do not exist currently. We will need demonstration projects. Microbicides will need to be manufactured. And a critical question is, who is going to pay? Many countries do not yet have tenofovir and tenofovir emtricitabine as first-line therapy available. Also, treatment for prevention, there is a lot of debate. How to prioritize who will receive earlier treatment? Again, who's going to pay in a resource-constrained environment? Some countries are exploring to prioritize pregnant women, such as Malawi, who has announced in the Lancet that they would start option B+, that's lifelong treatment for all pregnant women, regardless of immunological and clinical status. And some countries are exploring to prioritize serodiscordant couples, such as China. The new prevention technologies are highly depending on the knowledge of HIV status. We have to do major investments to increase HIV testing and counseling coverage and quality. There is a clear interaction of biomedical and behavioral interventions, and they have to be provided with existing prevention technologies, such as condom programs and harm reduction. What is WHO doing at global level? We are developing guidance for couples HIV testing and counseling and ART for treatment and prevention in serodiscordant couples. We are working on a rapid advice for daily oral pre-exposure prophylaxis for MSM and serodiscordant couples for use in demonstration projects. We need to have a better understanding how those services, if implemented, could be delivered. We are holding a series of consultations with the support of NIH to explore the strategic use of antiretrovirals for prevention and treatment, and are reviewing implications of use of antiretrovirals for prevention for programs in research. In conclusion, we have exciting success in HIV prevention sciences, but also with existing current prevention technologies. So the question is how to integrate new interventions in combination prevention approaches for specific populations and settings. There's hope for virtual elimination of HIV, new HIV infections. But we are also in a time of global economic crisis, and the question is, who will pay for this? Thank you very much.